one down there that's not. Actually, there's two that aren't, but these are examples of airspace consolidation, and there's also a couple examples of interstitial disease here. So let's start up here. These two are the same individual. And so let's start with this one. Is there a density change?
Yes.
On this one?
Mm-hmm.
Yeah. Okay. So the first decision is, how did the density change? Because when the lung's abnormal, the density, the shape, or both. See, if we've got atelectasis, that's a density and a shape change, isn't it? Density increases, the lung reduces in volume. That's a shape change. So what do we have here?
In the upper left.
Increase in density, and it's unilateral localized to the lateral portion of the upper left lung field. Okay, what kind of a border does it have?
Fuzzy.
It's a fuzzy border, isn't it? It's a fuzzy border. What's the distribution? Member number 6 of the 7 signs of airspace consolidation. What was number 6? What was 6? Actually, it was 7. I'm sorry. It was 7. 6 was the fuzzy border. We already got that. Unless touching a fissure boundary, exactly. Unless touching a fissure boundary. There's no round fissure boundary in the lateral upper left lung, is there? So this is a fuzzy border, and is that subsegmental, segmental, lobar bigger than lobe?
Segmental.
Segmental, okay. Let's say it's in the anterior segment, number 2, LUL, left upper lobe. Okay? That segment goes from here to here, and from here to here. So it's the whole entire segment? Because segmental means it's got to be the whole segment.
So it's subsegmental.
Subsegmental, isn't it? It's less than the whole segment. And without a lateral, we don't even exactly know where that is. It could be in 2, could be 1, 3, could even be in 6. Because 6 is up there. Without the lateral, we don't know where that is, because there's no way to use any silhouetting to know where that thing is. Okay? And I don't think it's even silhouetting the chest wall out here. So there's no way to know where this is. But this is sign 6, fuzzy border, and it's sign 7, subsegmental. This is classic airspace consolidation. Okay? Sign 6 and sign 7. Look at this one. This is also airspace consolidation. But do you see how this is all here and it's all here? This patient has bilateral medullary lung density. Agree?
Mm-hmm.
Would you say it's fuzzy?
Yeah.
Yes.
Yep. Would you also say cortical lung is clear?
Yeah.
Yeah. And that's what's called the butterfly shadow. And we talked about consolidation being localized, which is basically what sign 7 is saying. But we also looked at some bilateral examples. We looked at the butterfly shadow. We looked at the acino-nodular pattern, which is, there's one down there. That's the acino-nodular pattern, which is individual acini all over both lungs. And we also talked about bilateral patchy, meaning this scattered around both lungs. That's bilateral patchy. Sarcoid is a common one to do that, sarcoidosis. So we don't know what this is. This could, but it's likely an infection. It's most likely a pneumonia, subsegmental pneumonia. This is not a pneumonia. This
Pulmonary edema.
is pulmonary edema, which is water, plasma fluid. And these are the 2 most common reasons for having airspace consolidation. Remember, blood, pus, water, protein, cells. We said protein and cells are really rare. So blood, pus, and water are the 3 most common, and the 2 most common of that are pus and water. That's the 2 most common reasons. But this is airspace consolidation. There's also interstitial edema, which comes before this. This patient's still going to have interstitial edema, but you can't see it because it's covered up. It's actually silhouetted. You thicken the interstitium, but if you've got water density in the air spaces, you got water interstitium, water density airspace, it's this, it's a silhouette, you can't see it anymore. But this patient's still going to have interstitial edema, but it's covered up by the airspace edema. Do you think this one's going to have more symptoms than this one?
Yeah.
By a long shot, actually. Because all of this that's water has got very little gaseous exchange going on. And that's a lot of air volume to lose. It's going to have major dyspnea. Now, this one here. Also two different examples. Look at this one and compare to that one.
That would be more segmental.
Yes, this is segmental. And probably multi-segmental, but not lobar. You see? Because this is very dense. Unilateral localized density. Silhouettes the chest wall, silhouettes the ascending aorta at the mediastinum, and what's this? Minor fissure. Okay? We looked at one over there that had significant displacement on the minor fissure. The thing was sitting up here like this, right? Did the minor fissure move?
No.
So this cannot be atelectasis, exactly. You can have that density with atelectasis, but not with a minor fissure in its normal place. It just can't work. It just can't work like that. Do you see how this is a fuzzy border up here?
Mm-hmm.
There's also an area of density right here. Do you see that?
Yeah.
Now, this is well defined. What's this? Fuzzy. Now, where is this?
Basilar.
6? All 6 is that, right?
No. That's medial right lung base. What segments are there?
5,
5.
4?
Keep going back, then what?
6.
6.
6 is up here. This is 5.
Oh,
4 is over here.
5,
So it's
7, and 10.
5, 7, and 10, exactly. Front to back, this is 5, 7, 10. Is it in 5?
We don't know.
It's
Yeah, you do.
Yeah, it's in 5.
silhouetting the heart. Is it?
No.
No.
It's not silhouetting what? It's
The
not
heart border.
silhouetting this. Do you see that?
Right.
Because you can see the minor fissure over it. That means the minor fissure's here. If it was in 5, it would be right up against the minor fissure. You'd have water density in number 2, you'd have water density in 5. They touch. You'd see the fissure come along like this, gone. You wouldn't see the fissure. This fissure would be gone right here. And this would just all be one water density. So if you can see the fissure over it, the density has to be where?
7 or 10.
7 or 10. It's got to be behind the fissure. So it's this. Not this. Meaning this, it's got to be this. It's got to be behind it. 7 or 10. And that, without the lateral, we don't know. But that's an area of consolidation. So is this. But this is segmental in number 2. I think there's probably a little bit up into number 1, but not all the way to the apex. And 3, no way to know about 3 without looking at the lateral. So this is not lobar, but it's certainly bigger than this one is, isn't it?
Mm-hmm.
This is subsegmental. This would be segmental.
What's the little
Subsegmental, segmental.
border separating 2 from 1?
Up here,
Yeah.
that's just the distribution of it moving from one end to the other. Yeah. And it's moving through pores of cone, it just hasn't gotten all the way to the apex yet. That's all. And this is just an earlier example of this. That's all it is. Bilateral, yep, in close. It's just not all the way up here yet. This is just an earlier example of this. This is like half a butterfly shadow. It's still bilateral, still medullary, just not all the way up here yet. You know, give them another 3 or 4 hours, it may look like that one.
Is this from like severe high blood pressure, like cor pulmonale kind of thing? Or what?
No, this is typically, mostly this is related to left heart issues
Left.
and pulmonary venous hypertension. Most of the time. And because the butterfly shadow is a pulmonary edema pattern that's mostly related to cardiovascular issues. And it's typically left heart, like congestive failure, mitral stenosis, something compressing the veins in the mediastinum. The blood can't get out of the lungs fast enough, and the pressure goes up, which means the pressure also goes up in the capillaries, and it forces more fluid out of the capillaries. Yeah. Now, look at these here. One patient, one patient. Look at the density change here compared to here. Both lungs, subtle increase in density. This is a bilateral, widespread, non-homogeneous density change. Who had a question? You
I
did.
did have a question. Going back to the minor fissure, the silhouette sign, I was just wondering why you wouldn't just use the heart border to determine whether it was 7 or whether it was...
Well, it could be in 5. Heart borders here, it could be in 5. You only get a silhouette when it does this,
when it touches.
not when it touches. So we know, because we can see the fissure over the density, that they're not touching,
Okay.
which means then it's got to be behind
So
the
it can
major.
it can be in 5 and
No.
you'll still...
Because it goes all the way up to here.
Yes, I guess my question is now, you can have it in 5, but there still be a heart border?
Mhm.
It doesn't always silhouette the heart?
Only if it touches in 5.
Okay.
Yeah, that's what I'm saying. Heart border, 5.
Okay.
That's not a silhouette. This is,
Okay.
but this isn't.
I just thought that it always touched. But
No.
it doesn't. Okay.
Doesn't have to. Now, this is characteristic of interstitial disease. This is thickening the wall of the water bottle that we talked about the other day. Okay? This is thickening the wall of the water bottle. Nothing wrong with the airspace. Still plenty of air. That's why there's still radiolucency, and that's why we get non-homogeneous increase in density. Okay? This, does it look like just dots, or does it look a little bit like, kind of like a spider web?
It's ridiculous.
This is reticular. Probably even got a few dots, so we could call it reticulonodular or reticular. Doesn't matter. It doesn't matter between reticular and reticulonodular because the differential is the same. This is active. This is not. This is honeycomb. And honeycomb is a scar pattern. It's a very diffuse interstitial fibrosis pattern. You see this right here? That's the pulmonary artery. We never said the pulmonary artery should be 1, large, 2, stick out beyond the aortic knob, and 3, cover up the left hilus. We never said that. The pulmonary artery is supposed to be at least under or even slightly medial to the aortic knob and not cover up the hilus. So covering up the hilus tells us this thing is under a lot of pressure, and all of this scarring is compressing the capillaries. So if you squeeze the capillaries, is it going to be harder for blood to get through the capillaries? Yeah. And so the pressure's going to go up, isn't it? It's like standing with your foot on the garden hose. You didn't increase the volume of water. You're standing on the garden hose. Is the pressure going to go up between your foot and the hose and the tap at the house? Yeah, and if you stand on it long enough, the hose may even start to enlarge. Well, now you've got an enlarged hose, big pulmonary artery. And what's causing it? All the scarring. This is cor pulmonale. And what chamber's pushing blood through that big blood vessel? Right ventricle. And cor pulmonale is right ventricle failure because of lung disease. And the 2 main conditions that cause cor pulmonale are widespread fibrosis and emphysema. Those are the 2 main cor pulmonale disorders. And this is permanent. This can still go back to normal. This is an active interstitial pattern. Now this may end up like this if the patient's unlucky. And honeycomb lung is just the center of the wheel, and all the spokes go out to all the different diseases that can cause honeycomb lung. They all can end up, sarcoidosis can do this, neurofibromatosis can do this, tuberous sclerosis can do this, the rheumatoids can do this. This one was eosinophilic granuloma or Langerhans cell. And they can all end up like this. And then the problem is all the same, what it does to the pulmonary blood pressure. This is pulmonary arterial hypertension. Venous hypertension causes edema. Arterial hypertension does not. Because this is happening before the capillaries. This is happening into the capillaries and increasing the pressure and increasing the push rate. Venous hypertension does edema. Arterial does not. Now,